173 kV.
Nope, you're thinking of indium, I think. Gallium-67, Brittany.
Isn't that like, there's like 3?
So it's the so it's a cyclotron produced because it's thallium, gallium, indium. So gallium is the 3, it actually has 4, but we usually use 3, we use the lower 3.
Is it like 93?
Yep,
186?
close, 184.
And then 2, I don't even know, 2 something.
290 something. So it's about, or like 300. So 93, 184, 300. You know, various texts will say different things, but something like that, close to 100, 200, and 300. Okay. Indium 111, Chris, what do you got? What do you think? KEV.
I just went blank. I was going to say Indium 111, 193?
173.
173, just a number. Gotcha.
And there's a second one.
Yeah, that.
So like 247?
247. Thanks for helping him out. Good. All right. Next, DeMonte. I-131, KEV.
364.
364. Ezra, thallium 201, approximate KEV.
70 and 167.
Good. Right around 70s, common to use that one, 70, 71. Good. Hiba, I-123.
159.
Excellent. All right, moving on. All right. Francesca, tell me the radiopharmaceutical you would use for this exam. Lung perfusion.
Technetium 99M MAA.
Perfect. Rachel, what would you use for a Meckles?
It's technetium 99M pertechnetate.
Straight protectate. Teresa, bone marrow. We're going to do a combined, it doesn't matter. We're going to do a combined indium 111 WBC and bone marrow imaging. What will we use for bone marrow imaging?
I don't know. I'm having a brain fart.
When in doubt, what radiopharmaceutical will we always choose if we cannot remember?
Sulfur colloid.
Sulfur colloid is always a good choice. So for bone marrow, we would use the sulfur colloid. Do you remember the combined indium 111 white blood cell? We're trying to determine if it's bone marrow activity or it's actually an infection. We would use technetium sulfur colloid. Does everyone remember that? The combined study. Good. All right. Name a condition we can image, Allie, with osteomyelitis. Name a radiopharmaceutical we can use.
Indium 111 white blood cell.
Good, excellent. Give me another one, Andy. Osteomyelitis.
MDP.
Okay, and give me another one, Brittany. Hardest of them all.
Those are the ones that I was going to choose too. Can you give me a hint?
Starts with a G.
Gallium.
Gallium-67 we can also use for osteomyelitis. Remember the image we compared a bone scan with the gallium scan. And one of you had in your reviews, if it has increased uptake, just like on the bone scan, but even more so, it's positive on the gallium. Remember? That's another one. Okay, good. Chris, gastric empty solid. Name the radiopharmaceutical.
Sulfur colloid.
Okay. DeMonte, hepatobiliary. Name the radiopharmaceutical.
Mebrofenin.
Okay. Name another one.
Dizofrenin.
Good. Excellent. Ezra, gastroesophageal reflux. Name the radiopharmaceutical.
Was that sulfur colloid?
Sulfur colloid, you got it. Hiba, GI bleed. Name the radiopharmaceutical.
Red blood cells.
And if we have an active bleed and we want to find it really quickly and we know it's active, what could we use for GI bleed?
Sulfur colloid.
Excellent. Francesca, adrenal cortical scan. What's our radiopharmaceutical?
Octreotide.
No. So the cortical.
The other one.
This is the one we always forget.
It is. I wrote it down earlier. I don't remember.
Is it I-131 NP59?
That's right. So think of adrenal medulla and adrenal cortex. The adrenal medulla starts with an M. That would be the I-123 MIBG or indium-111 octreotide. Okay. And then the other, that's for medulla. The other one's the cortical. The adrenal cortical reason we will do the I-131 NP59. It's kind of the oddball. All right. Rachel, thyroid uptake. What do we use? Most common.
I-123.
I-123 sodium iodide, absolutely. Teresa, whole body thyroid scan. Whole body thyroid scan.
She's not here.
Oh, sorry. All right. Allie.
Is that like the Octreo scan?
So no, the whole body thyroid scan, when you see that, anything describing a whole body thyroid scan, it means a patient has thyroid cancer and we check them once a year to make sure there's no metastases throughout their entire body. Okay. We also do a post I-131 therapy scan on that person, but that's post ablation or post a large dose of I-131 7 days after. But this one, a whole body thyroid scan in general, patient has had diagnosed with thyroid cancer, thyroid removed, I-131 therapy. They come back once a year for 5 years as follow-up, and we give them, you remember this, 4 200 mic capsules, so 800 microcuries up to about a millicurie of I-123, and come back 6 hours later, and we scan their whole body head to toe and make sure there's no, it's like a bone scan, but it's for thyroid cancer. And 6 hours after we give them those capsules, 800 mics to a millicurie, we scan them head to toe with the I-123. Does that make sense? That's a tough one. Okay. Andy, adrenal medulla imaging. The
Octreoscan?
first one. What'd you say?
Octreoscan?
Octreoscan. The first thing I want you to think of with adrenal medulla is the MIBG. Okay? Think of that one first. Secondary would be Octreo, because Octreo's MIBG you'll see at children's. It's a lot more common to use the MIBG. The Octreo is pheochromocytoma. We'll get into that again next semester. But first and foremost, adrenal medulla, I-123 or I-131 if you're therapeutically treating the patient, MIBG. Secondary would be indium-111 Octreo scan. Okay, good. That's very good. Brittany, ERNA. What radiopharmaceutical will be used for an ERNA?
That doesn't even ring a bell for some reason.
What is an ERNA, guys? Give me another
MUGA,
name
tagged
for
red blood cells.
Tagged red blood cells. What is an ERNA, guys?
MUGA.
A MUGA. Yes, this is one of those tricks where you're like, wait, what's an ERNA? Equilibrium radionuclide.
That's for a cardiac MUGA.
Angiography. Yeah, it's a cardiac, it's a MUGA. The same thing as a MUGA, they call it an ERNA. Okay?
Also,
Yeah.
the thyroid, I thought I had in the PowerPoint, the whole body thyroid, you're only using I-123?
You can use, it's confusing, you can use I-131 as well, but typically these days to reduce the radiation, we use I-123 on a regular basis. I-131, if I gave you a choice, on the final, and I said which would be best for whole body thyroid scan imaging, I-123. If I said which would be best for thyroid therapy or ablation, I-131, okay? Not that they can't be used. They can be. It's not as common. Chris, liver spleen, radiopharmaceutical.
God. I just blanked out on that. I wanted to say tagged red blood cells, but that's not right.
That's hemangioma, right?
Yes, that's hemangioma. So this would be,
So,
I'm gonna go sulfur chloride again.
yeah, the one that, if you can't remember, pick it. Yeah, liver spleen. When I say liver spleen, you think of no patient restrictions. We inject sulfur colloid. And we wait about 10, 15 minutes. No restrictions. Put the patient on the camera. Might use a liver marker. Take some statics. Text is optional, as Francesca mentioned. But it's Kupffer cells. Remember that? Whereas the hepatobiliary is hepatocytes. Okay? Good. Excellent. All right, Ate, give me a dose for a bone scan. How much would you give for a bone scan?
20 to 30.
Yeah, I'd take that answer. I'd buy that for $1. 20 to 30 millicuries, sure. 20, 25 millicuries is probably most common. Good. Perfusion lung scan. Hiba, how much would you give?
Perfusion, is that 4 millicuries? Like,
Perfect. 3 to 6 millicuries is standard. I know Andy mentioned the book says 1 to 6. I would say the best answer is 3 to 6 millicuries. It does depend on the manufacturer, and we'll talk about that in radiopharmacy. 3 to 6 is a great answer for MAA lung perfusion. Francesca, thyroid uptake and scan. What would be the dose that you would give? So first you might want to say, well, it's this radiopharmaceutical.
It's I-123.
Okay?
The dose, it's going to be 4 capsules. Each are 125 microcuries.
So, okay, all right. So it depends on your site. Maybe 100 to 300 or 200 to 400. Somewhere in that range. 200 to 400 is probably common. Just depends, but yeah. And those are microcuries, right?
Mm-hmm.
200 to 400 microcuries. If you're starting to get in too much over that, like 800 mics, that's not a thyroid uptake and scan. That would be a thyroid whole body checking for metastases.
So the whole dose, sorry to interrupt you, the whole dose would be between 100 and 300, or each capsule?
Yeah, I would say, I would say 300 mics is a great answer.
Okay.
2 to 400, 300 mics, right in there.
Total, okay.
Some people give a little less, but.
Got it. Okay, thank you.
All right, thyroid therapy for cancer. Rachel, how much would you give? You're doing a thyroid cancer patient. They've come in for the therapy. Give me a number.
Was it, what did you say earlier? 600 microcuries to 1 millicurie?
So that one was 800 mics to 1 millicurie, but
Oh,
that was for a whole body. That was for a whole body thyroid. You're just coming back, and it's the whole body, like an annual checkup for thyroid metastases. That's 800 mics to 1 millicurie of I-123. Your patient you got was thyroid therapy for cancer. So they have had their thyroid removed, and now we're going to ablate the rest of the tissue. So it's actually usually a large thyroid dose, and they go away and they stay away from people and all of that stuff. How much would that be? So our thyroid therapy, if they have cancer, we give one amount. If they have a benign condition like Graves' disease or a single adenoma, toxic adenoma, we'd give a different dose. Your patient has thyroid cancer, and we're ablating their thyroid.
Was it 100 to 300 millicuries?
Usually 100 to 200, depending on where it's spread. Excellent. So 100, 150 millicuries would probably be about normal. Good. Excellent. All right. Allie, we're back to you. You've got a GI bleed. How much are you going to give? And it's an intermittent GI bleed. So how much are you going to give?
Like 20 to 40 millicuries?
Yeah, 20, 25 millicuries probably would be standard. And if it's intermittent and GI bleed, and with GI bleeds, you want to automatically think tagged red blood cells. Very few places will use the sulfur colloid for an active bleed. You need to know it exists. If it's in the question, you need to know it's a possibility to use. But mostly we're using the tag red blood cells and 20 to 25 millicuries. Andy, your patient's coming in for a hepatobiliary. How much are you going to give them?
8 millicurie.
Good answer. I'd say 5 to 10 would be about a range. 5 to 10. Some people go a little lower. Some people don't go as much as 10. But 5 to 10, 8 millicuries is very standard. 8 millicuries. Good. All right, Brittany, you're doing a thyroid scan only. Thyroid scan only. She gone?
Yeah.
Yeah. Okay. I think keep up with my. Chris, thyroid scan only. So first in your head, when I say this, what radiopharmaceutical?
I-123.
No, so if it's just the scan, you're probably going to think technetium. If I
Okay.
specify thyroid scan only, no uptake, start to think it's talking about just technetium. So
Got it.
technetium thyroid scan only, what would you give? I think this is perfect for you. I think you had this one earlier.
Did I? I don't
think
remember.
so.
I'm gonna say 2 to 6 millicuries.
Good. You went way lower than you did before. So 5 to 10 would be a good range
Okay.
for just the thyroid. 5 to 10 millicuries would be good. Thyroid scan only. You pop them with 5 to 10 millicuries of technetium right into their vein. Wait about 10-15 minutes. Put on the pinhole. Take some nice images, anterior, oblique,
That's just a straight tech, right? Just
straight to for technetate, 5 to 10 millicuries, right? Now, if you're doing the I-123 for the uptake and scan, that was, who did that one? Francesca, I think, 200 to 400 mics. So, but I would have to say, if I say thyroid scan only, start thinking technetium. If I say thyroid uptake and scan, you start thinking I-123, okay? Demonte, you're doing a gastric empty. What's the dose?
1 to 2 millicuries.
Yep. So you think gastric empty, sulfur colloid in eggs or oatmeal, solids most common, 1 to 2 millicuries. Excellent. All right, Ezra, you've got a thallium. It's a resting cardiac. It's thallium. So you inject thallium 201, you wait 15 minutes, put the patient on the camera and acquire some resting cardiac images. How much will you give the patient?
Will it be like 5 to 10 millicuries? The
It's
range?
a little high for thallium. So thallium is probably about 3 millicuries.
I'm thinking systemibia, I think.
Yeah, so thallium, because it's, if you remember, it's a cyclotron produced, a little longer half-life. We usually do about, I'd say the textbook probably says about 3 to 6 millicuries. I would say 3 to 4 is more standard, but 3 to 6 would be a reasonable answer for thallium 201 cardiac resting imaging. Okay, Francesca, myocardial perfusion, the stress portion, myocardial perfusion, what would you say?
About 30 millicuries of systemibia.
Good, yeah, so 20, 25, 30, that would all be reasonable, okay? Because usually you give, 10 for a rest, 30 for a stress, it's very common. So 20 to 25, that would be reasonable. Nothing's exact, but it makes sense. Rachel, you've got a patient, this is perfect for you. Patient with Graves, and you're gonna do hyperthyroid therapy. So you had before the thyroid cancer with I-131, and we got to, it's about 100, 200 millicuries for that. Now you have a hyperthyroid for Graves. So you're gonna give I-131 therapy for Graves. How much are you gonna give that patient?
50 millicuries.
Good guess. So about 10 to 15. About 10 to 15. Yeah, 10 to 15 is great. I was given 10 millicuries when I had mine, and I kept telling the radiologist, I only need 8. I'm telling you, I don't need 10, I just need 8. I was right, he was wrong, the thyroid's 10, but just remember that. So 10 to 15 is kind of standard for that. Now, if it is a thyroid therapy for the single adenoma, a couple of you showed that image in there. That's the one that all the other cells are laid back and relaxed, and there's this single nodule that's kind of rogue, overactive. That's a little more resistant to I-131. We need to hit it a little harder than we do with Graves, because Graves is taking over the whole thyroid. We don't have to give as much. If we've got the single adenoma and they're coming in for hyperthyroid therapy, we would give more than Graves. So typically, they're about 15 to 30 millicuries for that one. Okay, so everyone's got it. Graves is the lowest dose, about 10 to 15 is common millicuries of I-131. Solitary toxic overactive hyperfunctioning nodule, single nodule, that's probably 15 to 30 millicuries of I-131. You don't do any repeat or follow-up imaging with those patients, usually they're done. Thyroid cancer is a separate case. We're going to treat them with I-131 for thyroid cancer, depending if it's localized or spread to their lungs or bones. We start at 100 millicuries, and depending on the extent of the disease, we might give up to 200. There are some sites that will give a little more, 50, 300, not as common though. 1 to 200 is common, okay? Everyone's got the doses. You did well on the doses and the radiopharmaceuticals. Okay, now we're done with that. Ellie, well, strontium is an analog to what?
Is it potassium or calcium?
Good, calcium. Calcium is right. What is an analog to potassium?
Thallium.
Thallium. Good, excellent. So we just hit 2 right there. Good. So, if we see kidneys on a bone scan, Andy, would that be normal?
Yes, that's part of the biodistribution, I believe.
Absolutely. So we wouldn't freak out. That's normal. Good. All right, Brittany. Typically, skeletal metastases greatly involve what? Axial or appendicular skeleton?
She's not here.
Oh, sorry. I did cross her off. Chris.
That would be the axial skeleton.
Good. Axial. Mets. Axial. Excellent. Demonte, if we have no osteoblastic activity in a region, how would it appear on our bone scan? Hot or cold?
Cold.
Cold. Good. So they would call it maybe like photon deficient. You know, they try to make weird words for cold. Cold. No photons. Photon deficient. If there's no osteoblastic activity, if we have increased osteoblastic activity on a bone scan, it's going to be hot, increased activity. Excellent. Ezra, as far as primary bone neoplasms, who's the modality that would first be involved in that diagnosis? Primary bone diseases and cancers.
Is it a patient with a history of bone cancer? No.
So if they have a primary bone cancer, they most likely had an x-ray or some other procedure. We're not like the first step. How are we involved though? Let's say somebody does have a primary bone cancer and they come to us. Why do you think we're doing the bone scan?
Is it because their x-ray showed up abnormal?
Yes, so their x-ray showed up abnormal. They believe, or they found out they have a primary bone cancer. Now they've come to us. What's our role in that diagnosis and disease?
Just to see how much the cancer has spread.
Right. So we can see their whole body. So they would call on us after it's been diagnosed to check the extent and spread of the disease. How widespread is the disease? Does that make sense for everyone? Okay. We're not the first step in those, but we are involved to look for metastases. Good. All right, Hiba. The osseous phase of a bone scan. When would you scan the patient? If I said, go get the patient for the osseous phase, where are we at in a bone scan?
Is that the whole body?
Yeah, so it's
Yeah.
osseous phase. Yep, osseous phase is the whole body. It's probably 2 to 3 hours after the injection that we're scanning them. It's actually in the bone. So that's called the osseous phase, the whole body or the delayed phase. good. Just trying to bring up some wordings that they would use on exams. All right, Francesca, why do we use strontium 89 chloride?
For a therapy?
Right, what
bone
kind
pain?
of therapy?
Bone pain.
Alleviate bone pain. So it's not to cure them, it's to alleviate their bone pain, as you said. Very good. All right, Rachel, did she leave? I think so, right? Okay. Allie, what's the diameter of a capillary?
It's like 90 micrometers or 0.9 micrometers.
Okay, so you're on the right track. I know what you're thinking of, 7 to 10 microns, so usually 7, 8 microns or micrometers. 7 to 10 is kind of a range textbooks will give. 7 to 10 microns or micrometers is the diameter of typical capillaries. And then you said 90, right? We'll get to that in just a second. So they usually create the particles in our MAA kit to be 10 to 90 microns in diameter, because then knowing that the capillary is 7, 8, no more than 10 microns, the particle will go into circulation and get stuck in the lungs so we can image it. It's just slightly larger. So we make our particles of the MAA, the particulate size, 10 to 90 microns, never over 150 microns. They'll start blocking larger vessels and we could have a problem. Does that make sense? We'll talk about that more in radiopharmacy again. All right, Andy. All right, what do you know about the particles? This is actually perfect for you. What do you know about the particles in the MAA dose as far as, like, if I gave 100,000 particles to a normal adult, what do you think about that?
That's too little. You have to go up to at least 200,000.
Yeah, so our range is 200,000 to what?
700,000.
700,000. 100,000, who might we give 100,000 particles to?
Pulmonary hypertension patients.
Yeah, so typically pulmonary hypertension, we would give about 150,000. Then I'd start thinking about pediatrics, right? Because we said neonates, we give what? New babies. New babies, we give how many particles? Anybody?
50,000.
50,000. Children, pediatrics, that's age like 1 to 18. How many do we get?
150 to 300.
Usually it starts at 100 and then it goes up to 350. 100,000 to 350,000 for pediatric population. It's scaled by mass, how big they are, okay? The neonate new baby was 50,000. Pediatrics is typically 100 to 350,000. Pulmonary hypertension is probably about 150,000 particles. Could be a little range, 100 to 200,000, sure, about 150,000. Normal adult patient, 200,000 to 700,000. If we gave a normal adult patient only 100,000, it's not going to be a good appearance, okay? Probably blotchy. And definitely decreased intensity. We don't have enough, okay? Okay, you know that. Okay, we went through that. PEs usually start where, Chris?
Usually with extremities as deep vein thrombosis, then they get dislodged and make their way up to the lungs.
You got it. Yep. All right, DeMonte. Metastatic pheochromocytoma. A patient has metastatic pheochromocytoma. What radiopharmaceutical might you use to treat them? This is actually an out-of-the-box kind of question. So it's a therapy for somebody with metastatic pheochromocytoma. So if you think therapy, so first of all, pheochromocytoma, what do you think of? 2 radiopharmaceuticals.
MIPG and Octreoscan.
MIBG and Octreoscan. Now, let's start with the first one, MIBG. It's usually what goes with the MIBG. Is it technesium MIBG?
I-120.
I-123, but I've just told Demonte it's for therapy. So instead of I-123, because we don't have any betas there, what are we gonna hook on there?
I-131.
I-131 MIBG, we could metastatic pheochromocytoma, right? Okay, that's the kind of critical thinking I expect, I might throw on something like that. All right, Ezra. A patient's thyroid gland is diffusely enlarged and it has excessive thyroid hormone. What condition do you think this is?
I'm sorry, can you repeat that again?
The patient has a diffusely enlarged thyroid and has excessive thyroid hormone.
Would that be hyper?
Hyper, and what condition of hyper? It's uniformly
Grave?
taking up the material, but overactive, uniformly overactive.
Is it Graves' disease?
Graves' disease, good. Hiba, tell me the difference between technetium perpectinate and I-123 as far as trapping and organification.
So both are trapped, but only the iodine is organified.
You got it. Rock that out. You guys got it. Yes. All right. Francesca, your patient you just injected for pertechnetate for a thyroid scan. How long will you wait to scan the patient for their images?
30 minutes, 15 to 30 minutes.
Yeah, I'd say probably we used to do about 15 minutes. So 15, 20 minutes. 30 minutes is a little long, I would say. 5 minutes, not quite enough. So 15, 20 minutes. Good. No. Allie, you're still here. All right. So let's see. This is perfect. Okay, so when looking at the blood test results in a chart of a patient with hyperparathyroidism, what do you think might be elevated in their blood work?
Of their
Calcium?
level, calcium.
Calcium,
Sorry.
yeah, exactly. All right, Andy, you're doing a dual phase single tracer parathyroid study. You're going to repeat the images when? These are the delayed images. When would they be taken?
3 hours after.
Good, 2 to 3 hours, excellent. So some people do it a little sooner. They do like 90 minutes, 120 minutes, something like that. Yeah, but 2 to 3 hours is common. Good. He's gone, Chris. Pheochromocytoma, what organ do you think of first? When I say pheochromocytoma, what organ or system would you think of? Thyroid, parathyroid, renal, adrenal, bone.
Pheochromocytoma. Renals?
So it's adrenal. So it's, we talked
Adrenals.
about it with the endocrine system. So it's the adrenal gland, right? So pheochromocytoma, typically it involves adrenal glands, which are glands that sit on top of the kidneys, right?
Kidneys.
Good. Quick. Let's see. Demonte. Adrenal cortical imaging. What are you going to give? You're going to inject the patient.
I-131 and N95
Almost. NP59.
and P59.
Yes. Good. I know that's a tough one, and I've repeated it a couple times. All right. Ezra. Why do we, when we do a salivary gland, why do we put the patient's head way back?
So we don't mistaken that with the thyroid.
You got it. Yes, because remember with salivary gland, what radiopharmaceutical are we using?
For straight protectinate.
Great tech. So it's going to go to the thyroid too. So we want to make sure we don't have any problem with distinguishing those salivary glands from thyroid activity. Excellent. All right, Hiba. Esophageal transit. What? Someone comes in for one. What radiopharmaceutical are you going to get? Give me a little bit about how you prepare that radiopharmaceutical. Esophageal transit.
That's the sulfur colloid.
And what do we put it in?
Is that just in water?
Yeah, you got it. 300 mics of the technetium sulfur colloid in water. You got it. Francesca. Gastroesophageal reflux. What is considered abnormal?
Anything over 4%?
Good. Anything over 4%. And if it's, who would we use an abdominal binder on?
Adults.
Adults only, and anything over 4% at any pressure if we're using that binder. Good. All right. If we are deciding to use sulfur colloid for sulfur colloid for a GI bleed, how do you think we should position it? Now, you might not know this because no one uses it anymore, but we inject the patient with sulfur colloid because it's an active GI bleed. Now, okay, where does sulfur colloid go? Sulfur colloid, where does it go? We give it for bone marrow, remember, and it goes 3 places.
Liver, spleen.
Spleen, liver, bone marrow.
Good, liver, spleen, bone marrow. So if we're using it for a GI bleed study, it's gonna go to liver, spleen, bone marrow. But in this case, for the GI bleed, we only wanna see what?
Like the intestines.
The intestines. We wanna see their guts. We don't wanna see their liver. We don't wanna see their spleen, right? So we wanna be real careful how we position that one so we're not taking all those counts that are gonna go to the liver, spleen and interfere with our good image, right? So we wanna make sure we only include maybe the top portion of the liver and spleen and just, so we can kind of see, yeah, we're in the right spot. We don't want to put the whole liver and spleen in the field of view. All the counts will be taken from there. We will not be able to see that bleed. Okay, does that make sense? That's the kind of critical thinking you guys are getting to at this point. Even if you didn't know it, you could probably deduct it. Good job. Andy, most Meckel's diverticulum contain what type of tissue?
Stomach tissue.
Stomach tissue, good. Chris, what kind of cells are involved in a liver spleen scan?
Liver, spleen would be comfort cells.
Good. How about a hepatobiliary scan? Which cells
Hepatocytes.
are involved? Good, hepatocytes. Excellent. Demonte.
I have to go.
Okay, no worries. Demonte, after a fatty meal, the gallbladder is stimulated to what? What does it do? After you eat a Big Mac, what's happened to your gallbladder? Does it relax? Does it contract? Does it what?
It contracts.
Good job. Ezra, if we don't see a gallbladder by 4 hours, what is it called?
Is it acute cholecystitis?
Acute cholecystitis. Excellent. Heba, what does administering morphine sulfate during a hepatobiliary do?
It
Sphincter of
contracts
Oddi.
the sphincter of Oddi. It contracts the sphincter of Oddi and fills up
Fills
the gallbladder.
Good. Good. All right. Okay. That one. Francesca. Normal hepatobiliary. When are we going to see what? At what times would be considered normal? We have to see 3 things, right? What do we have to see for a normal hepatobiliary?
Liver, gallbladder, and small intestine.
Good. When should we see the liver?
Right away.
When should we see the gallbladder?
Within 90 minutes. 1 hour.
Usually by 15 minutes.
Oh, 15
30,
minutes.
15
Oh, okay.
to 30 is kind of the range for gallbladder. Usually that's normal. Now that can vary greatly if they haven't eaten in days, obviously. And then how about the GI tract? When should we see that by, typically?
Just after that. So 30 minutes? 30 minutes
You
to an
got
hour?
it. Yeah, 30 minutes or so. We should be seeing that GI check. You got it. That was completely normal. Excellent. We're back to Allie. We're dwindling down here. Method of localization for a gastric empty, Allie.
Was that compartmental?
Compartmental. Yeah, we give him the tracer, goes into a compartment called the stomach, and we image that compartment. Excellent. Another compartmental is the technetium red blood cells within the blood compartment. Okay, so that would be for GI bleed, MUGA, hemangioma. Those are all within a compartment. Good. Excellent. Andy, tell me the test that we use to detect the location and extent of myocardial ischemia.
Rest and stress test.
Nuclear medicine rest and stress test. Good, excellent. Brittany's gone. We're down to DeMonte. So we talked about this thallium 201 in cardiac world having this unique property that the technetium radiopharmaceuticals don't have. What is that unique property called?
Redistribution.
Redistribution. Technetium, MyoView, and Sestamivy, it remains fixed in the myocardium, whereas thallium has a unique property that it redistributes, which is really nice if we're trying to find out if the tissue is almost dead. It's ischemic, or we're even thinking it might even be infarcted completely, but there's a little hope. We can do this thallium imaging, and it can show us if there's a little glimmer of hope in those patients. Good. So if we're going to do thallium redistribution imaging, let's just say we inject the patient, we wait 15 minutes with thallium, we injected 3 to 4 millicuries, wait 15 minutes, put their arms above their head, do a cardiac SPECT imaging with thallium in them, and that's called the resting images. Then we call them back so many hours later and we do redistribution imaging. We can do 24 hours, but there's a time frame prior to that where we can do redistribution. So look for that area that we saw was not lighting up and it appeared that it's either infarcted or ischemic. We're going to follow up with that spot. What is the time frame for that second set of images? Redistribution imaging. What do you think?
24 hours, maybe? Less
No,
than?
we do a 3 to 4 hours. This one was on the homework, and I do have the key posted. 3 to 4 hours, we take an image of that thallium, and then if it's still in question, we can do a 24-hour. And we'll talk about this more next semester in advanced cardiology. Good. Hiba. So when we're doing, we've got a patient. They're in for a stress test. They're on the treadmill. They're running. They hit their peak heart rate. They let you know they only got about, so much time left. They're getting tired. So you inject. They hit their target heart rate. So the cardiologist says, go ahead and inject, Hiba. You inject. Can the patient just immediately stop right after you inject them?
No, you want them to keep going for a little bit.
How much is that little bit?
I can't, I'm trying to think.
1 minute minimum.
Just 1 minute, okay.
1 minute minimum. You at least got to get them keep going for 1 minute, or it will not be a valid study if they all of a sudden just slow down. Give the tracer, they got to go 1 minute. That's why you always instruct patients on treadmills. You got to give me a 1 minute warning before you're going to poop out, okay? Before you're going to get tired and just jump off, give me 1 minute's warning. I'll inject. You walk 1 more minute for the tracer to circulate properly, okay? Then it gets fixed in the heart, and then it will show us, no matter how long we wait, it'll look just as the heart looked while they were on that treadmill. That's what's unique about technetium, tetraphosmin, and Sestamivy. Okay, good. Fantastic. What can reverse the side effects of our vasodilators? What are the vasodilators, first of all, for cardiac?
Was this my question? I'm sorry.
Yeah, so
Aminophylline?
Aminophylline reverses the effects. So we've given, a vasodilator like Lexi or adenosine or dipridamole, and the patient is having side effects. we can give aminophylline to reverse those effects. Excellent. All right. Allie.
We're close. We're almost done. Sorry.
Your patient has severe asthma. In fact, they're wheezing right now, but they're here for a cardiac stress test, pre-surgical workup for their knee. They can't walk on the treadmill, so they're going to have a pharmacologic stress test, but they're wheezing, okay? And they have breathing problems. What pharmaceutical are you going to use with that stress test?
Dobutamine?
Dobutamine, good. So dobutamine is the one we can use. That's why you see the cardiologist listen to the patient's lungs before they start a vasodilator study. If they're already having constriction to their lungs, their airway, their breathing, they will not give them those vasodilators. Because remember what a vasodilators do? They dilate blood vessels, not only to the heart, to the lungs, to the stomach. That's why they feel sick. The blood vessels are dilating. They dilate all blood vessels. So although Lexi is a lot better than some of the older ones we use, they might just skip right to dobutamine and say, nope, I'm going to do a dobutamine because it acts differently than a vasodilator, right? What does dobutamine do? Andy, how does dobutamine work? Why is it different? It's not a vasodilator. What does dobutamine do?
I'm not entirely sure about dobutamine.
I mean, have you seen that? Probably not. It's
I've
not
seen
as common.
She mentioned it once, but she didn't end up using it. So
Okay. So dobutamine is it actually increases the contractility and oxygen demand of the heart. Dobutamine is the next closest thing to a treadmill. It is literally as close to a treadmill as you can get, because the patient's going to feel their increase in heart rate. You're going to see the increase in heart rate. It's just like a treadmill. The patient's laying there, but they still have to hit that peak heart rate, just like on an exercise. So it's kind of I would say it's the worst test out there, because they're laying still, but they feel like they're running a marathon, okay? So their heart's racing, you're watching the heart slowly go up. We give the dobutamine usually starting at 5 mics in slow 3-minute increments. Every 3 minutes we increase the dose of dobutamine, so they don't, just instantly feel it, but they do feel it. And oftentimes with dobutamine, we give them the squeezy balls, have them move their feet. It makes them feel better, and it gets their heart rate up without having to give them more dobutamine, okay? So dobutamine is not a vasodilator. It actually increases the contractility and demand of the heart, and it's primarily saved for patients with lung disease or active wheezing, something like that, or they can't have vasodilators, okay?
Amy, I think that they gave dobutamine to a patient who had had coffee. Is that something?
That's another one. Yes, very good. So if they've also not followed the caffeine restriction, then they can't give the vasodilator, but they could do dobutamine. So that's another reason. Snuck a Starbucks in the morning, we're still going to get you. You're doing dobutamine. Very good. Excellent. All right, Chris is gone. Demonte, if we're looking at cardiac function only of the heart, what's the name of the exam?
Mugga.
Mugga, what's another name?
Erna.
Erna, good. Equilibrium gated angiography. Equilibrium radionuclide. Good. Okay. Excellent, excellent. You guys did fabulous on that. All right, so now I'm just going to go specifically through. I'll try to skip the ones we went over 100 times already. Here's exam 1 for endocrine, okay? This was exam 1. Hiba, you're still here, right? I have a list here. Let's see. Would surgical removal of the thyroid gland cause hypothyroidism?
I think it could.
Yeah, so if we removed your thyroid gland, you definitely would be hypothyroid. Absolutely. How about if we ablated your thyroid with radiation? Could you be hypothyroid then?
Yeah.
Yeah, absolutely. And how about if you had Hashimoto's thyroiditis? Is it possible that it appeared you had hypothyroidism?
Yeah.
Yeah, good, excellent. All right, next one. You already did that one. How does decreased levels of thyroid hormone affect your metabolism? Allie, would it be hypo or hyper? If you had decreased levels of thyroid hormone, what would your metabolism be? Hypo or hyper?
Hypo.
Hypo, good. All right, Andy, 13-hour half-life and 159 keV. What am I talking about? We're on endocrine system, so probably something with the thyroid.
I-133.
I-123, 13-hour half-life, 159 keV. You got it. Demonte, 8.1 day half-life, 364 keV.
I-131.
I-131, got it. Ezra, a patient came in for a radio iodine uptake and scan, and they had a CT with contrast 2 weeks ago. Can we do our scan?
No, it has to be longer than 2 weeks.
Yeah, 2 weeks, we'd say no. A lot of places do at least 3 weeks. So if it was just 2 weeks, probably not. Because all the sites will be saturated with that contrast, and that competes with what we're looking at, the binding sites on the thyroid. It takes up that contrast, and then our material can't take it up. They're already taken. Could be with shrimp, fish, seafood, contrast. Okay, good. Hiba, why do we measure the patient's thigh during an uptake and scan?
They check for the background counts in the body.
Yeah, what's circulating in the blood and not in the thyroid. That's right, background, absolutely. Francesca, some sites have, tell me if this is true or false, some sites have NPO for 12 hours for patient prep for thyroid uptake and scan.
True.
True, yeah. So some sites are 2 to 4 hours, some are 12 hours NPO. That was one I think some of you missed today, that you didn't need to be NPO. A lot of times it is NPO. A lot of textbooks will even say 12 hours NPO before thyroid uptake and scan. Good, excellent. All right. We already did that. Allie, you injected a patient with straight protectanate for thyroid scan. You see a linear band of activity on the scan. What do you think that is?
Like part of the esophagus.
Yeah, so it's esophageal activity. So we want them to probably drink some water. I think Brittany described how they give someone lemon or something like that to clear out the salivary glands. Make sure that we're not having any activity that's unrelated to the thyroid and it's causing some confusion in our images. So if you ever see that with any iodine or technetium scan, have them drink some water. Sit up, drink some water, take the scan again. It'll probably clear. Good. Andy, we got that already. Let's see. Good, you got that. You got that one. True or false, Andy? A method of parathyroid imaging can be performed with pertechnetate and thallium-201 as a subtraction method.
True.
True. It's one of our older ones that we can do. Why? Because thallium not only is for heart, it images what?
Thyroid?
Tumors. So pertechnetate and
tumors,
thallium. So pertechnetate goes to thyroid and thallium goes to tumors. So we can tell. Good. Excellent. Devante, what is the tumor of TENS condition talking about? It's a disease of the adrenal gland. Tumor of TENS. 10% in children, 10% outside the renal system, 10% are malignant, 10% are bilateral, and 10% are less than 10 centimeters in diameter. What's the disease I'm talking about? You've had this one before.
I know we had that. I don't know.
Anyone?
Pheochromocytoma.
Pheochromocytoma, you got it. Ezra, if we want to image the adrenal medulla, we already said this probably too much. What are the two radiopharmaceuticals?
NDM-111 octreotide and I-123 MIBG.
Good. And alternatively to I-123 MIBG, instead of the I-123, what else could we use?
I-131.
Just to know that's an option. Very good. Excellent. Hiba, cortical, adrenal cortical. What's the radiopharmaceutical?
I-131 NP59.
Yeah, you guys are so good. All right, Francesca. So we're gonna do an adrenal imaging, and we're gonna use an I-131 radiopharmaceutical. So it doesn't matter. It could be the I-131 NP59, or it could be the I-131 MIBG. Okay. What do you think about patient prep?
Oh, no leafy greens, no seafood.
Okay, so adrenal imaging for adrenal cortex or adrenal medulla using I-131. So we want to image the adrenal glands. What do we usually use I-131 for?
Thyroid.
Thyroid. We're not looking at the thyroid. In this case, we're only looking at the adrenal medulla or cortex with I-131. We're not looking at thyroid. We do not want to see thyroid.
Right.
What would be a key patient prep to remember if we give a radiopharmaceutical with I-131, but we don't want to see the thyroid? We give something called a thyroid blocker.
Oh.
We're going to block the thyroid. Do you remember one of the names of them?
No, I do not.
Anyone?
Was that SSK?
SSKI, supersaturated potassium chloride, Lugol solution. Does that ring a bell?
Yes.
We also do a brain imaging we'll talk about next semester. It's I-123. It's DAT scan. I-123 base. We don't want to see the thyroid. Our job to be a good technologist, protect that patient's thyroid from anything that's going to go to the thyroid. We don't want it. The adrenal medulla, adrenal cortical imaging. If we're using I-131, block that patient's thyroid. Okay. So we use Lugol's, SSKI or potassium chlorate. Good. All right. Octreotide, Indium-111. What would be typical imaging time? I think you guys had this one in the review today. When would we image we inject someone with Indium-111 octreotide, when would we scan them?
24 to 48 hours.
Yeah, so some places will do 4, 24, and 48, okay? So,
Amy,
it's like in the textbook, if they say, go ahead.
Do some places do 72? I remember.
They might even do 72 depending on what they see, because it stays in the body for a while. That would be usually by a radiologist would determine if they need that one or not. But like if a board asked you, board question, octreotide, do we image immediately? Oh, heck no. The earliest would be 4 hours. Sometimes we just wait 24 and 48. Okay? Good. All right. Octreotide is a radio labeled peptide of 8 amino acids, and it's an analog to what, Francesca? Let's try this one.
I have no idea.
Anybody remember this one?
Somatostatin.
Somatostatin. Good. We're going to cover that one again next semester, so don't worry. Kind of a tough one. You guys got the I-123 uptake questions, no problem. Okay, what is secreted into the anterior portion of the pituitary gland by the hypothalamus? Iba reviewed this with you.
Was it TRH or am I messing it up?
Yeah.
TRH.
Yeah. All right, let's see. And then the anterior pituitary produces what?
TSH.
TSH, good. Good. And then you went over MITs and DITs. You guys got that. Mono, iodo. You guys got that. We went through that. What is the most common type of thyroid cancer?
Hyperparathyroidism.
Thyroid cancer.
Oh,
Papillary, then follicular, then medullary, and undifferentiated. Of those four, papillary, follicular, medullary, and undifferentiated, which two cannot be treated with I-131? Chris went through this.
Medullary
And
undifferentiated.
good, yeah. Good, so we treat papillary and follicular with I-131. Excellent. All right.
You said papillary was the most common?
Yes.
Okay.
And follicular is second. We treat both of those. Good. Okay, so that's endocrine. We're done with endocrine. Pulmonary, we're on to number 2. Pulmonary. How does avascular necrosis appear? Increased or decreased, Allie, on a bone scan?
Decreased.
Good. How about metastatic disease, Allie? How would it appear? Increased or decreased?
Increased.
Good. How about osteo?
Increased.
Good. How about Paget's?
Increased.
You got it. Good job. Andy, why do we ask a patient to empty their bladder prior to bone imaging?
Try to lower the uptake on the bladder as much as possible.
Yeah, so it's to reduce the radiation to the bladder and to prevent the bladder activity from obscuring the pelvis region. Those 2 reasons. Okay, so if you it accumulates in the bladder and it's sitting there, obviously it's radiating. So, I mean, it's very little, but yeah, we want them to empty their bladder.
Amy, I gotta head out.
Yeah, no worries, no worries. Anyone can
All right.
leave at any time.
Thanks a lot.
Yep, take care. Bye-bye. All right, Demonte. Okay, we got a super scan. Your patient has a super scan bone scan. How would the bone activity appear? Increased or decreased?
Increased except for in the arms, I guess, and the legs.
Good. And then how about the kidneys and bladder?
There won't be any.
Decreased or absent? Good. Excellent
Go
job.
to Amy.
You gotta go? Yeah, no worries. Let's see. What's the difference between rib lesions and cancer lesions on a bone scan? Ezra, how do you tell the difference between rib lesions, like a motor vehicle accident, versus metastatic disease?
I think Mets, it's gonna show up, right?
Next will be not organized at all. It'll be
Really messy, yeah.
shaped differently and messy. Yes, it's a good way to say it. Whereas the fractures will be kind of like, depending on the accident, kind of in a row or
Yeah.
organized.
More organized,
Or
yeah.
circular. Yes, good. All right, we already went through that. All of those. Actually, all right, we'll keep going here. I think we did this. Yep. Okay. Yes. All right, strontium 89 chloride has a half-life of 50.5 days. Is that true? Francesca?
yes, true.